Welcome to Cardiology Section 1. Follow with us as we review coronary artery disease.
First we'll define some heart terms. So we're talking about preload. This is the left atrium contracting. It pushes blood down into the left ventricle, and this causes the left ventricle to stretch. That stretch is the preload. A ventricle, when it's stretched, it's a muscle, so it's a lot like a rubber band. When you stretch a rubber band, the more you stretch it, the farther the rubber band will fly. So by using preload, this pushes extra blood in the ventricle, stretches a little bit, makes the muscle more likely to squeeze harder. So preload allows the ventricle to squeeze harder and push more blood out. Something to know that a patient who's in atrial fibrillation, since the atrium are quivering, there is no preload. And somebody who's in atrial fibrillation will not have an S4 heart sound. All right, afterload, it's another way of saying the blood pressure. It's the pressure that's behind the aortic valve. So if my blood pressure is 120/70, then the 70 is the pressure that's behind the aortic valve that the left ventricle has to build pressure up before it can open that valve and push blood out. So typically a person builds the pressure up to 120, that ejects the blood out to the body. Then as the pressure starts to drop, the valve closes, and the pressure left over in the aorta is 70 millimeters of mercury. So that's where we get the diastolic and the systolic pressure. Afterload is generally the diastolic number. So somebody who has a blood pressure of 240/120, that blood pressure is very, very high, and the left ventricle has to push open the aortic valve up to 120. That just opens it, and it has to have a higher pressure to push it out to the body. So the blood pressure is 240/120. That means that the left ventricle has to work harder to open up the aortic valve. If you go to the gym and lift weights, you're going to get bigger muscles. Well, the ventricle was only pushing 120/70. It wasn't having any troubles, but now it has a lot higher pressure to open. So you get LVH, left ventricular hypertrophy. The left ventricle has to get bigger to open up the aortic valve. This is why blood pressure causes hypertrophy of the ventricle. And somebody who has hypertension, and you hear somebody say give them an afterload reducing agent, you're saying reduce the blood pressure, that's the diastolic pressure that's in the peripheral arteries. So ACE inhibitors dilate the arteries, lower the blood pressure. Calcium channel blockers, those agents are afterload reducing agents. Contractility is just the strength of the actual muscle itself. Digoxin actually increases contractility, and verapamil, a calcium channel blocker, actually reduces contractility. Systole is when the left ventricle builds up pressure and then squeezes the blood out to the body. Diastole, however, is when the ventricle is at rest and it's being filled with blood from the atrium. Diastole has two phases. It has a passive and an active phase. The passive phase of diastole is when the two valves open up and blood just falls with gravity into the ventricle. Because the mitral and tricuspid valves are open, blood just falls into the ventricles themselves. The active phase of diastole is when the actual atrium, the left and the right atrium, contract and squeeze blood down into that ventricle. So when the atrium contract in that active phase of diastole, and it's that last little bit of blood it pushes down into that ventricle, that's the preload that's pushed into both the right and the left ventricle. In cardiology, we primarily talk about the left ventricle because that's the one that pushes blood out to the body, but most events occur both in the left and the right heart. So the active phase is when the atrium squeezes and pushes blood into the ventricle. So the left atrium squeezes blood down into the ventricle. That is your preload, or the active phase of diastole. They're all the same thing. Now, if you happen to have a very stiff ventricle, when the left atrium squeezes blood down into that stiff ventricle, it will make a S4 heart sound. To get the S3 heart sound, you'll have a dilated or very thin-walled, weak heart muscle. During the passive phase, when all the ventricle valve opens up, the blood just splashes into the ventricle. That's what creates the S3 sound, because you have this big, open, cavernous left ventricle. Blood splashes down in there. Specifically when they're overloaded, it all comes back rushing into the left atrium and then it splashes into the ventricle. That makes the S3 heart sound. The S4 heart sound is made by the active squeezing of the left atrium against a thick heart muscle. So the S3 isn't a weak heart muscle, the S4 happens in a thick heart muscle. Both of the S3 and S4 heart sounds happen in diastole though. And this is called the ejection fraction. It's not a stroke volume, it's just a calculated value. And what we're saying when we talk about an ejection fraction is, here's the left atrium, blood will just fill up into the ventricle. So here's actually the ventricle being filled. Blood just splashes in the passive phase. Then the last phase, the active phase, this squeezes, pushes blood in here, causes these walls to stretch a little bit more, giving us our preload. Then this blood shoots out into the aorta and out to the body. So this person here, he filled up with 100% blood, he filled up with 100% blood. But when this ventricle squeezed, it pushed out 55% of the blood to the body and only 45% remained. This guy here, he had 100% in here. When he squeezed, it pushed out 25% of the blood and 75% remained. So what that means is that this is a normal functioning heart because it pushed out 55%. This is what we call normal, 55 to 60. This has a very low ejection fraction, meaning that the ventricle is thin-walled and it couldn't push much blood out, so only 25% got out to the body. So that's what we're talking about. An ejection fraction is most people with a normal ejection fraction is about 55 to 60. A low ejection fraction is under 40. So now we'll talk about coronary artery disease, acute coronary syndrome, angina, acute myocardial infarction, and treating acute coronary syndrome. So coronary artery disease is an inflammatory process, involves the arteries in the body. It starts with specifically when we say coronary disease, we're talking about the ones that lie in the heart. It starts with the deposition of lipids as early as the age 17, 18 years old, and this causes inflammation and narrowing of the artery and causes a constant remodeling process. So the risk factors for coronary artery disease, these are our non-modifiable and these are our modifiable risk factors. They'll ask a question, all of the following are not modifiable except, or all of these are modifiable risk factors except. So we'll put 3 of these here and then we'll throw 1 of these up there and you have to know which is which. Any of these risk factors here actually accelerate coronary artery disease. So remember, most coronary arteries are very small. Think of a McDonald's straw being about one of the largest coronary arteries that surrounds the heart. So the key to preventing coronary artery disease is actually controlling the risk factors. So the DASH diet, exercise are vital to their health, maintaining weight, controlling diabetes, fixing the blood pressure, stopping smoking, controlling the cholesterol, and undergoing stress management. You got to control these things to slow down coronary artery disease. Half the patients that have their first heart attack die without ever getting to the hospital. 80% of this half are at the age of 65. So just out of the blue, you're 65 years old and you have your heart attack and never make it to the hospital. So it's all about prevention. Atypical presentations in coronary artery disease, we'll talk about these first. Old people, the elderly, they often present with a syncopal event instead of chest pain. They often pass out. And this is why when somebody has a syncopal event, they always call cardiology because they'll make sure it wasn't a heart attack. Diabetics often present with silent ischemia, so they don't have any chest pain. Instead, they present in heart failure or very, very short of breath. And ladies are very difficult to treat for coronary artery disease because often abdominal pains can look cardiac and cardiac pains can look abdominal. This is because the vagal nerve travels down through the throat, through the heart, and then down into the stomach. It's a very undifferentiated nerve, but it's why when you have chest pain and that nerve gets stimulated, you get nauseous. It's also why when you have belly pain, since it's the same nerve and the brain has a hard time differentiating where it's coming from, belly pains can mimic heart pain and heart pain can mimic belly pain. And then there's non-cardiac pains. You can read about this. These are just descriptions of things that are probably not the heart. These are the signs and symptoms of your typical heart attack. So it's a substernal chest pain. Remember the Levine sign when they make a fist and put it over their chest. Diaphoretic, short of breath. They can have anxiety, impending doom. Blood pressure can be up or down. They can often have nausea. May or may not have back pain. They can have some of the symptoms, none of the symptoms. It depends on any comorbid conditions. So when we're talking about coronary artery disease, here's your normal vessel. This is your blood vessel, by the age of probably 30 or 40. This is actually the plaque here, the yellow. There's the lumen. And this is just a small rupture that's repaired itself. So this is somebody who has unstable angina. They get a small rupture. It impedes a little bit more of the lumen, reduces blood flow to the coronary arteries and the heart muscle, so it gets a little pain, but it doesn't completely occlude. The non-STEMI, here's the plaque here. It ruptured, but it didn't completely occlude everything. But this patient will have chest pain, but they won't have the Q wave or the ST elevation on the EKG. And then this patient, it completely ruptured off this fat deposit, blocks the lumen, so this is going to be your ST elevation MI. So what is acute coronary syndrome? Acute coronary syndrome is what we call somebody who comes in with chest pain that we think is due to cardiac abnormality. So angina, unstable angina, a STEMI, which is a ST elevation MI, and a non-ST elevation MI. Those are the three things that define acute coronary syndrome. So somebody comes in with chest pain, and I think it's acute coronary syndrome. It's either angina, non-STEMI, or STEMI. So to define a heart attack or angina, there are three criteria that we use. So I'm going down to the emergency room, somebody's got chest pain. I'm going to get their history, and I'm going to see if their chest pain is consistent with a cardiac-like cause. So they got crushing chest pain, radiates to the left arm, radiates to the jaw, they're diaphoretic, they're nauseous. Those are clues that make me think they're also diabetic, a smoker, and their dad has history of coronary artery disease. That's a good chest pain story. EKG changes I'm going to look at, looking for ischemic changes. If they have an ST elevation right away, I'm thinking heart attack. If they have depressions or flip T waves, I'm thinking they have ischemia, maybe a heart attack. And then I use the cardiac enzymes. So they have to have two of these three criteria to call it a heart attack. So the ST elevation, which is the most severe or the most critical where the artery is completely occluded, they will have a good chest pain story and they will have EKG changes with ST elevations. Just these two criteria mean they're having a heart attack, and I send them right to the cath lab, the cardiac cath lab, where we can put a stent. They don't need cardiac enzymes to define it as a heart attack. You just need two of the three criteria here to call it a heart attack. So we use all three to help differentiate them, and I'll show you the rest of them. So all three of them will have chest pain. Here's the angina, the non-STEMI, and the STEMI. ST elevation MI, non-ST elevation MI. Angina. So they all have chest pain. Could be a similar story. The key with angina, though, the pain is less than 30 minutes. Both of these are greater than 30 minutes. EKG. It'll be negative primarily, no ST elevations. As non-STEMI, also negative. The STEMI will have ST elevations. You'll have these T waves that go up like this, big ST elevation. In the patient who comes in, we're ruling out acute coronary syndrome. I only need two of these three things here to call it a heart attack. So with a STEMI, I get the positive chest pain and EKG changes. It's already a heart attack. So this patient goes to urgent cardiac cath. Angina and non-STEMI is where we have to do the differentiation, and that's where the troponins help us. The troponins will be negative in angina because the pain will be less than 30 minutes, and they'll be low positive in the non-STEMI patient. We do get the enzymes in the STEMI patient, but we didn't need them to call it a heart attack. But when we get them, we'll find them to be high and positive and very high levels. So the treatment for angina, once we know it's chest pain, EKG, we admitted them, 3 sets of negative troponins, we just treat them with medications and we do an outpatient stress test. If you have a non-STEMI, you've got chest pain, the EKG's no ST elevations, but we find low positive troponins. They wait the day with medications, they're treated, the next day they get an elective cardiac cath. And then the STEMI patient has positive chest pain, positive EKG changes, they immediately go to the cath lab the same day. The reasons is that the studies show that ST elevation MIs are best treated with urgent cardiac cath, they have the best outcomes, whereas patients who have non-ST elevation MIs and angina, those patients do better with medications and staged workup. These are some other examples of pain that you can have in different locations, so you can read this. Just pause it and look at it. Alright, so angina specifically, there are two types. There's stable and unstable. We define stable once we have a history. Unstable angina is any new chest pain that lasts less than 30 minutes but has a good chest pain story. They've got risk factors, EKG is negative, they have good story, and troponins are negative. So you can also have somebody who has unstable angina who has a history of stable angina. What I mean by a history of stable angina is somebody who came in unstable angina and they either refused cardiac cath or they don't want any kind of specific treatments. Maybe they're 85 years old and they just want medications to be treated. They don't want to do any interventions or anything. So they came in, pain goes away after 30 minutes. We give them nitro, their pain goes away. So this is the patient who has what's called stable angina. They have a predictable pattern of angina when they have activities. So they walk for 1 block and they take a rest, the pain goes away. Or they walk for a block and they take 2 nitro tablets every time and it goes away. So they walk a block, take 2 nitros, it goes away. They walk a block, get chest pain, take 2 nitros, it goes away. So that's their stable angina pattern. So unstable angina means the first time they've ever had it, or they were stable and it became unstable. What I mean by becoming unstable is now instead of walking a block and resting, the pain goes away, they walk a half a block and they got chest pain and it doesn't go away. That's now considered unstable. So the diagnosis of angina, we know good chest pain story, EKG with nonspecific changes, and negative troponins. We send these patients to outpatient stress test, walking. If they remain unstable, in other words, they get the pain, it lasts 30 minutes, we give them nitro, but then a little while later they get the pain again, then it goes away with nitro and they get it again. This patient's considered unstable and we'll end up doing the cardiac cath. So the treatment for the stable angina, ACE inhibitors, beta blockers, aspirin, nitroglycerin, statins. I'll show you I have a whole mnemonic on the things that we use. Now there is a special subvariant of angina that you need to know about. It's called Prinzmetal. This is coronary vasospasm. The artery actually spasms. They don't have a blockage, it spasms. So the difference with these patients is that a patient who has Prinzmetal angina can get up in the morning and walk 5 miles and have no pain. This patient here will walk a block and get chest pains. But this patient here will have chest pain at night and it'll look just like a heart attack. If this person here having their variant attack at 2 in the morning gets woken up from sleep, if we were to do an EKG right then, we would see ST elevations. If we didn't know they had Prinzmetal angina, let's say it's an old lady, she wakes up at 2 in the morning, crushing chest pain, rescue brings her right to the ER, we get her story and she's got a good chest pain story, the EKG shows ST elevations, I would immediately send her to the cath lab. When we get to the cath lab, they would look in the arteries and they would see that the arteries were just spasming, and that's how she would get diagnosed with Prinzmetal. So the treatment for Prinzmetal angina is calcium channel blockers. This prevents the spasm. The difference that you're going to see on the questions are Prinzmetal angina is during the event, while they're having Prinzmetal angina attack, it will look like an ST elevation MI. When they're not having any attack, the EKG will look normal. When they're not having the attack, these patients can walk for miles and miles and miles and have no symptoms. It's usually at night when they sleep, it wakes them up. However, the stable angina patient, they walk a block, they get chest pain, they need nitro to relieve it. These patients look significantly different than your Prinzmetal patients. Non-coronary artery disease causes, these are some other things that can cause angina. Aortic stenosis can do it, LVH can do it, and hypertrophic cardiomyopathy in kids. The reason is in LVH and hypertrophic cardiomyopathy, the muscle actually gets so big that the coronary arteries can't actually bring enough blood or enough food to feed the size of the heart that's there. So when they're at rest, it does just enough to feed the heart and keep it happy. But as soon as they start moving, the heart pumps harder, it needs more oxygen, and the blood supply that goes there can't maintain the amount of oxygen it needs, and that's why they get the chest pain. So that's why hypertrophic cardiomyopathy and LVH people can get chest pain okay at rest, and then they move just a little bit, overwhelms the amount of blood that the heart can bring to itself, and then they get the chest pain. Stress testing, this is where we do a nuclear medical medicine exam. It takes several hours to do. We can do it with walking, which is the ideal. Walking nuclear stress is the #1 method for treating somebody with angina. You screen them to see if they have coronary artery disease as the cause. If they can't walk, we use medications. So a good description of angina for you. 75-year-old male, he's got hypertension, diabetes, high cholesterol, 60-year pack smoker, comes to the office with chest pain. When he walks upstairs, pain lasts for 2 to 5 minutes, goes away when he rests. He's admitted to the hospital for 23 hours. So he's got a good story, a lot of risk factors, so I say good story. EKG, we found out his sinus, no changes, and we find his enzymes are negative. So we look and we see his troponins, 1, 2, 3 are all negative. Here's the ranges here. So the key to this is the chest pain is less than 30 minutes, no EKG changes, or mild ones, no ST elevations, and the negative enzymes. We call this angina. This is how they're going to present it to you. So then we got our acute myocardial infarction. This is the non-STEMI and the STEMI. The difference between these two is that the enzymes are both positive, the good chest pain story, but this guy here doesn't have the ST elevations in the non-STEMI, he has ST elevations. So cardiac enzymes, just so you know, there's CPK, that's our general muscle. Then there's the CKMB, which is specific for the heart, as a heart marker, the CKMB. So it peaks first out of all the different cardiac muscles. The CKMB peaks first. The troponin peaks very shortly after that. Troponins are the most sensitive and specific to cardiac damage. CKMB is specific to the heart, but not as sensitive and specific as troponins. This one will peak first, this one will peak there shortly after, but this one will last, it says 3 days, it'll last up to 10 days in the blood. EKG, you're going to have to know the zones in a heart attack, and I have a better picture than this, so we'll do that in a second. These are chest pain stories suggestive of a heart attack. Remember any band-like squeezing, Levine sign where they put a fist on their chest. Worse with exertion, radiates to the jaw. These are all signs suggestive of an MI. There are glycoprotein inhibitors. They may or may not ask a question about these agents. These are antiplatelet agents. They're called glycoprotein inhibitors or 2B3A inhibitors. It's a medication that's given only IV. So they give this IV antiplatelet agent primarily after somebody gets a stent to help keep the stent open. They give it for 12 hours just after the stent to give one more antiplatelet agent to help keep the stent open. We also use it in unstable patients. I don't think they'll ask that question. So non-STEMI and STEMI. These are both heart attacks. Both have positive troponins. Both have a good story. He's got ST elevations. He doesn't have ST elevations. Both will get treated with a cardiac cath. He'll get an urgent cath. He'll get an elective cath the next day. So the story is, both have the same risk factors as the angina guy, but this guy walks upstairs and the pain lasts for 2 hours, was relieved by nitroglycerin. We admitted him. So he has no more chest pain. EKG shows sinus, no changes, but he had positive enzymes. They were low. First one was negative, but then the second one and the third one came back positive. Whereas the STEMI, this patient has 2 hours of pain. It continued on, didn't get better with nitro. His EKG shows ST elevations. He immediately goes to the cath lab. We did get troponins anyways, and we see that they're very high. This is the 12-lead interpretation, so you need to know these areas here. What they're going to do is they're going to give you an EKG and shows ST elevations in certain leads, and you have to know the names of them. So V1 and V2, these are the orange leads here. This belongs to the left anterior descending artery, and this is the septal heart attack. V3 and V4 are also part of the LAD, and this is called the anterior. The green ones, 1, AVL, V5, and V6, these belong to the circumflex artery, and these are called our lateral leads, and these are our inferior leads, these red ones here, 2, 3, and AVF, and they belong to the right coronary artery. This is the territory. So if you're looking at the heart, you can see the right coronary artery feeds the territory here on the inferior side, LAD down the front of the heart, circumflex down around the left side of the heart and around the back. So the way they're going to ask this is they're going to show ST elevations in V1, V2, V3, and V4. They're going to say what kind of heart attack is it, and you're going to call it an anterior septal wall MI. Or they're going to say that V3, V4, V5, and V6 all have ST elevations, and you'll call this an anterior lateral wall MI. Or they're going to have 2, 3, AVF, and V5 and V6, and you're going to call it an inferior lateral wall MI. So they're going to make you define the heart attack based on where the leads are. So this is just your 12 lead here, and we labeled the leads by color so you'd know which section was which and which artery fed that territory. They may ask you which coronary artery. Patient presents with a heart attack in leads 2, 3, and AVF. What coronary artery feeds this territory? The right coronary artery. All right, so now treating our acute coronary syndrome. All the medications you need to know and how to treat it. It's called Mona B cash pad. That's the mnemonic. So everybody knows who Mona is. That's your morphine, oxygen, nitro, and aspirin. Her full name is actually Mona B cash pad. This is how you treat acute coronary syndrome. I go to the ER, I see somebody having a heart attack or what I call acute coronary syndrome. These are all the medications I take in consideration. So the first medicine, starting in order, is morphine. Morphine is a vasodilator, so it dilates the arteries, increases blood flow to the heart, reduces anxiety, which can lower the blood pressure, makes it easier for the heart to work. Morphine is a good medication. Oxygen. The way we give oxygen is I start with a nasal cannula up to 6 liters. If that doesn't keep their O2 sats where I need them, I use a non-rebreather mask, the NRB. That goes up to 15 liters. And then I have a bridge before I have to intubate the patient called CPAP. It's continuous positive airway pressure. These are those BiPAP machines. They look like those little astronaut masks. They put them over their mouth and nose. This forces oxygen in, forces the airway, the lungs to open up, and they oxygenate better. This is your bridge between the mask and intubation. Very, very good tool to use nowadays. Nitroglycerin, we start off with sublingual. Put it under the tongue. If they get chest pain relief, I give them nitro paste. I put an inch of paste on their arm or their chest. I give them sublingual nitro. If they don't get chest pain relief, then I will use IV nitroglycerin. So start with sublingual under the tongue, and then if they get pain relief, paste. If they don't get pain relief, I give them an IV drip. With aspirin in a heart attack, I always give them 325 milligrams. If they've got 162 milligrams at home, I have to give them another 162. If I don't know, then just give them 325 where you're at. Beta blockers, there's 4 of them that we have to know. So we got our metoprolol, which is our short-acting. We got our carvedilol, esmolol, and labetalol. Metoprolol has got a short and a long-acting version. What you need to remember is that the metoprolol is a nice short-acting version medication that we use for injection fraction that's over 40%. And then the only FDA-approved beta blocker for somebody who has an ejection fraction less than 40% is carvedilol. So a patient comes in, they have a heart attack, their ejection fraction is 35%. What beta blocker will you use? The answer is going to be carvedilol. Patient comes in, they have a heart attack, the ejection fraction is 50%. What beta blocker will you use? I'll use the metoprolol. Now there's 2 other ones, esmolol. This one's a great rate control agent. This beta blocker here is given IV, and it only lasts in the system for 1 minute. So it's a medication you can put in somebody who's got a fast heart rate, and you can control their rate. So you can use this agent here for a thyroid storm, for somebody with AFib, any kind of a fast heart rate that you want to use a beta blocker for to slow it down. And you can turn it off and it'll rapidly get out of the system. And then you got your labetalol, which is our hypertension drug of choice. It's actually La for the alpha, and then the beta for its beta property. So it's an alpha beta blocker, and it's our hypertensive drug of choice. Next, we have calcium channel blockers. The key to this thing here is that we only use this particular one here if they have AFib. If they don't have AFib, I don't use calcium channel blockers in acute coronary syndrome. If they have atrial fibrillation and I need to control their heart rate, then I use the calcium channel blocker cardizem, or diltiazem is what it's called generic. So I use diltiazem in acute coronary syndrome only for rate control. It has no role in a heart attack. ACE inhibitors are always given in somebody having a heart attack. They prevent the remodeling or the restructuring of the heart muscle. Statins have 2 properties. They have both a short-term and a long-term property. Short-term, they're anti-inflammatory agents, antiplatelets. Long-term, they are anti-lipids. So statins given early in a heart attack, as early as possible, actually improve morbidity and mortality because they're antiplatelet and anti-inflammatory. Give them long-term, they're anti-lipids, and they help prevent the progression of coronary artery disease. Very good drugs. They do have their own side effects. Rhabdomyolysis and liver problems are the primary ones. Remember, with statin therapies, if somebody has a heart attack, initiate maximum therapy. Now, the H in monobicashpat is either heparin or Lovenox. Remember, heparin and Lovenox are in the same class. Lovenox is also called enoxaparin. That's the generic name. So we got heparin and enoxaparin. We use heparin for the STEMI, and we use enoxaparin for the non-STEMI and the angina. We do this for a reason. Heparin has an immediate reversing agent, which is protamine sulfate. So doing an ST elevation MI, I don't want to give them a long-term anticoagulant that I can't reverse when I'm getting ready to do surgery. So I use heparin, which can be reversed and gets out of the system rapidly. Whereas Lovenox, once you give this enoxaparin, it's in the system for 12 to 24 hours, and they bleed easily on this stuff. So if the patient's going to have emergently cardiac cath, I use heparin. If they're going to wait and sit for the night because they're a non-STEMI or an angina, we use Lovenox. And then if they're a non-STEMI, we just stop the Lovenox in the morning, do the cath, or just don't give it in the morning, we just do the evening dose. And then the angina patient, will stop it and we'll send them home and do the outpatient stress test. Why is Lovenox given for these two? Because all the studies show Lovenox is far superior to heparin in preventing cardiac events from worsening. So Lovenox for these two, heparin for this. Plavix is an antiplatelet agent. Aspirin works on thromboxane A2, or one of the receptors on the platelet. It blocks it and prevents the platelet from sticking. Plavix works on the ADP receptor on a platelet, also preventing them from sticking. So Plavix is always loaded 300 milligrams, and then you do 75 milligrams daily. Then we have the agent amiodarone. Amiodarone is our antiarrhythmic of choice for once the patient having a heart attack has ventricular tachycardia or VFib. So this is similar to our calcium channel blocker, only used if they have the VT or the VFib. Otherwise, we don't use the amio. So calcium channel blocker only if it's for AFib rate control. Amiodarone only if they have VT or VFib. It does work on AFib, but don't look at it that way. Use Mona B cash pad. AFib, use calcium channel blocker to rate control it. VTAC, use amiodarone. And then the other D is dopamine, dobutamine, and diuretics, and occasionally digoxin, but I wouldn't use the dig in a heart attack. So dopamine, this is for a low blood pressure. Dobutamine for cardiogenic shock. Diuretics for somebody who has congestive heart failure. These are only if drugs. So the calcium channel blocker, the amiodarone, and the dopamine, the CAD, these three are only used if they have a problem. I give all of the other ones every time. Big thing to know about amiodarone is this particular drug has a lot of side effects. It can lead to pulmonary hypertension, elevated LFTs, hypo or hypothyroidism, and it's, see the iodine right here, IOD, people who are iodine allergic are allergic to amiodarone as well. So before you start amiodarone, you need to get pulmonary function tests, LFTs, and a thyroid panel. So cardiac cath criteria. Once a patient presents to the hospital, you have 90 minutes to get them to the cath lab. The criteria are, we have two types of stent. We have a bare metal stent and a drug-eluting stent. The bare metal stent is one that doesn't have any extra medicines on it, and it will heal and be completely endothelialized. In other words, when we put a stent in, it's like a scaffolding on the inside of the artery, and it pushes all the plaque into the wall, and scaffolding holds open the artery. The body, within a month, will actually grow a layer of skin over that piece of metal and create a nice smooth lumen with endothelial layer over it. A bare metal stent will do that in 30 days. Sometimes, though, it'll over-endothelialize and it'll close the stent up. So they came out with drug-eluting stents. Drug-eluting stents have an antibiotic on them that helps inhibit the endothelialization and the platelet aggregation, prevents them from clogging again. So what happens with them, though, is that it takes an entire year for the endothelialization to occur, or that layer of skin to grow over them. So a bare metal stent only needs Plavix for 30 days because then it's endothelialized, where somebody who gets a drug-eluting stent must be on Plavix for a year. There are some criteria for cathing somebody outside the 90-minute window, and that's if they have any of these symptoms here. And then we have to talk about thrombolytics. If you are not within 3 hours of a hospital that can do a cardiac cath, then you need to use thrombolytics. The trick with thrombolytics, they have symptoms of myocardial ischemia, they have the ST elevations, and no cath lab available. The absolute contraindications are any kind of brain problem, is pretty much how I remember it, but any kind of intracranial hemorrhage in the past, known vascular lesion, any kind of cancer in the brain, any kind of recent stroke, these are all contraindications. So any kind of brain bleed, they got an aneurysm or they're actively bleeding, don't use it. They have some relative contraindications. You have to memorize these if you want to know them. There's no secret to it, guys. I don't know one. You just have to memorize them. The nice thing in clinical practice is you have a checklist. But for the test, you have your brain.